Hi, I'm Dr. Matt Schlumbrecht. I'm a gynecologic oncologist at Sylvester Comprehensive Cancer Center, and it's my pleasure today to speak with you about some considerations in gynecologic oncology, specifically our diverse patient population here in South Florida, cancer survivorship care, and some resources available. Today, we'll be discussing the diverse and unique community of the GYN cancer population in South Florida, some of the unique needs of our GYN cancer survivors and how to care for them, and then some available resources to support the care that you're going to provide to them. So let's start with unique diversity of gynecologic cancer patients in South Florida and some survivorship considerations. So in the next few minutes, what I want to do is describe the unique distribution of gynecologic cancer diagnoses amongst the women in South Florida and to review some specific considerations in their survivorship care. So we know that the demographics in the United States are changing, and Florida is directly impacted specifically because of our large immigrant population. When we look at census data, we know that 35% of the US Black population is now made up of Caribbean nationals. 50% of the non-Hispanic Black immigrant population to the US is Caribbean. The Hispanic population of Miami-Dade County is more than 50%, with substantial representation all throughout the Caribbean and Latin America, inclusive of countries like Cuba, Venezuela, Colombia, the Dominican Republic, and others. We know that the population of Black immigrants in the United States has risen by 71% in the last 10 years, and that the largest share of newly arrived Afro-Caribbean immigrants to the United States goes to Florida, with the greatest representation from Haiti and Jamaica. And so understanding how diverse our community is, it really emphasizes the need to be aware of some of the unique disease presentations and some of the unique survivorship considerations for these patients as well. So first, I want to start with discussing cervical, vaginal, and vulvar cancers that are all related to infection with the human papillomavirus. So we know that Latina women have a higher risk of HPV-related diseases, even though their outcomes are better. South Florida, unfortunately, has the highest age-adjusted incidence of cervical cancer in the United States. A lot of this is likely due to our immigrant population and large groups of women who have not gained access to HPV vaccination, as well as those who've not been able to undergo routine screening for cervical cancer. Now, it's important to realize some of the other pertinent associated cancer risk factors with HPV-related cancers. One is smoking. We know that smoking markedly increases the risk of post-treatment complications. These patients get obstruction of their intestines. They get fistulas, which are abnormal connections between two adjacent tissues. And these are the patients who chronically will need greater referrals to services like chronic pain, palliative care, and gastroenterology. It's very important when you see these patients to encourage them to quit if they have not attempted to already, and or refer them to a smoking cessation program. We also know that unfortunately HPV-related disease often occurs in women of low socioeconomic status. And so things to really kind of assess under the context of financial toxicity are basically if needs are being met at home. And these are basic needs like food and shelter. They may have more profound social needs than some of your other patients. Often healthcare is not a priority, so it's important to make sure that they're up to date on their other cancer screenings, but also that social work gets involved if there is concern about home safety or things along that line. It's also important to realize that when people have HPV-related GYN cancers, that there is an increasing recognition they're going to be at a higher risk for anal cancer or anal dysplasia. So all of these patients should be referred to an anoscopy clinic where we do high-resolution anoscopy and anal pap smears. We have one of those within the Gynecologic Oncology division at Sylvester, and so this should be routine referral. One other consideration amongst these HPV-related diseases is that they're often seen more in patients who have HIV-positive disease. So if your patient has cervical, vaginal, or vulvar cancers and has not been tested for HIV, she should have that done. Endometrial cancer is cancer of the lining of the inside of the uterus, and we've seen kind of a big demographic shift in endometrial cancer over the last 20 years. Now, there's multiple types of endometrial cancer, but there are several risk factors that are particularly important in our catchment area here. One is obesity. We know that obesity is one of the biggest risk factors, and that's because women who are obese have higher levels of circulating estrogen, which stimulates the endometrium to grow. In Florida, obesity is a substantial problem, with the rate being reported as high as 37%, and it's expected to climb to above 50% within the next several decades. Survivorship is a really great teachable moment about healthy eating, so consider referral to nutrition for your obese patients. Exercise and increasing physical activity, so doing an assessment of whether physical therapy would be indicated, if exercise oncology would be indicated, and then making sure that you're screening for other obesity-related medical comorbidities. So even though these patients may have been treated and cured for their endometrial cancer, they're still at high risk for diabetes, hypertension, heart disease, and other conditions. Our unique population here in South Florida, and specifically our racially and ethnically diverse group of women, which have varying ancestral backgrounds, has really demonstrated a very different kind of epidemiology of endometrial cancer relative to other parts of the United States. We know overall that high-grade and aggressive endometrial cancer is increasing in the US, but we've got higher rates of this disease here than other centers in the country. We know that Haitian women, for example, are particularly at high risk to get really aggressive endometrial cancers and unfortunately do very poorly from it. Um, Overall, when we kind of look at where people are born, though, and specifically Caribbean nativity, meaning if they were born in the Caribbean, that does seem to be protective in terms of risk. And so these are actually data that we published here a couple of years ago with one of our epidemiology colleagues, really looking at risk of high-grade or aggressive endometrial cancer by race and ethnicity and nativity, specifically if Black women were born in the United States or the Caribbean. And what you can see here is that relative to white women, Hispanic women have about the same risks, but Black women have markedly elevated risks, although those risks are a bit attenuated if they were born in the Caribbean. This suggests that there may be some changes in the genome, that there may be some sort of protective effect. It's still unclear, but important to recognize that you are going to see variable risk depending on where somebody was born. Ovarian, fallopian tube, and primary peritoneal cancer is not the most common GYN cancer, but it's the most lethal GYN cancer. And unfortunately, that's because most women are diagnosed when they become symptomatic at stage 3 or stage 4 disease. We know in Florida that non-Hispanic Black women have a higher risk of ovarian cancer than white women, but Hispanic women have an overall lower risk. The reasons for this are unclear, but one thing that we can appreciate is that genetics are important in ovarian cancer. We know that about 1 in 4 ovarian cancers are hereditary, meaning that it's something passed down in the family. We know that Afro-Caribbean women have very high rates of gene mutations that cause hereditary breast and ovarian cancer, and that Bahamian women especially are at very, very high risk for BRCA1 mutations, higher actually than Ashkenazi Jewish women. It is standard of care for all ovarian cancer patients to get germline genetic testing. So if you see a patient who has not had genetic testing, then she absolutely needs to be referred to the genetics clinics for evaluation. It's also very important as you're doing risk assessment for other hereditary cancers that every time you see the patient in follow-up, you have a discussion about any changes to family history. So any new patient or any new family members rather that have breast, ovarian, prostate, pancreatic cancers, melanoma, as these may suggest the evolution of a more clinically relevant hereditary cancer syndrome. The figure that I've placed down here was actually generated by one of our colleagues here at Sylvester, looking at the distribution of pathogenic and likely pathogenic germline mutational variants by country. And you can see that when we look at the hereditary breast ovarian cancer syndrome genes, there's substantial variation by country of birth. And so this also suggests that there's going to be variation in kind of the genetic predisposition as well as the genetic phenotype of these diseases. And so in summary, why is it important to understand cancer patterns in our community? And one's because we can't put people into boxes. It's really important to understand how unique each patient is and be able to personalize our care relative to her background. And really understanding who somebody is, where they came from, and what their culture is going to be the first step into understanding kind of disease etiology and how we can intervene to help patients live longer with a better quality of life. And that's the goal of our survivorship care. Now I'd like to talk about general gynecologic oncology survivorship care. So the Society of Gynecologic Oncology puts out recommendations for surveillance on a regular basis. So we're going to talk about some of the considerations that we have for our GYN cancer-specific patients. The first is screening for cervical cancer recurrence. So we follow these patients very intensely for the first several years, and then once they get out to 3 to 5 years and then beyond, we don't need to do pelvic exams as frequently. Now, one of the things that's really important is that pap smears are indicated just once a year. Patients will often request pap smears more routinely than that, and historically, we used to do them every 3 months. But it's been recognized that yearly pap smear is sufficient to really kind of detect recurrence that may occur at the cervix. There is no guideline for routine imaging, be it chest x-ray, PET-CT, CT scan, or MRI. So patients should be discouraged from getting routine imaging outside of a concern for recurrence, which would be manifested by bleeding, increasing pain, or substantial changes to their bowel or bladder habits. Now, once somebody gets a pap smear, it's really important to realize that about 1/3 will be abnormal. And the majority of those are abnormal because patients have undergone radiation, and the radiation induces changes in the cells at the cervix or at the top of the vagina, which when we look at the cytology will appear abnormal. Now, most of these abnormalities are considered low grade, so ascus, which is atypical squamous cells of undetermined significance, or LSIL, which is low-grade squamous intraepithelial lesion. And a very large retrospective study actually demonstrated that in the absence of a visible abnormality on the cervix, if a patient has a low-grade pap smear, they can be followed up at a regular interval without colposcopy or referral. So if you've got a patient who's had cervical cancer diagnosis, even if the pap is HPV positive, if there's a low-grade lesion, it does not need to be pursued. However, for women who've got ASK8, which is atypical squamous cells, cannot exclude high grade, or HSIL, which is high grade squamous intraepithelial lesion, or if there's something that you can see on their pelvic exam at the cervix or the upper vagina, these patients do require referral back to GYN oncology, as their risk for a recurrence right there at the cervix is higher. Now, we do a lot of things that are going to affect patients' bone health. And the current guideline for the US Public Health Service Task Force is to start screening with a DEXA scan at age 65 in female patients who don't have any risk factors. But, younger postmenopausal patients who may also be at elevated risk for bone loss would be considered folks who should undergo screening. We know that during menopause, when there's a reduction in the levels of circulating estrogen, that there's going to be an increased fracture risk. And there are certain things that we see in cancer treatments, such as reduction in body weight, that may increase the risk of bone deterioration and accelerated bone loss. Now, there is something called a FRAX score, which can be found online and can be used when risk factors are present to determine if a patient is at risk, specifically for a lumbar or a femoral fracture. And it helps essentially provide an estimate of the 10-year probability of major osteoporotic fracture, and that really helps determine when somebody should be initiated on treatment. Now, when we consider somebody who's had pelvic radiation, the radiation actually covers about 25% of the patient's bone marrow and increases their risk of a pelvic fracture to about 10%. Now, some of these may just be insufficiency fractures and not kind of a large-scale hip fracture, but they may be symptomatic even if they're low volume. Most fractures are going to occur within 2 years of patients completing treatment. Radiation really does affect the bone resorption and bone turnover, as well as small vessels within the bone. So bone healing capability is reduced relative to those patients who don't have or have not had cancer treatment. It's also important to recognize that when patients have poor diet, they've had a reduction in their amount of exercise, or if they've got underlying vasculopathy specifically associated with smoking, that they will also be at higher risk for bone fracture. Another consideration is that the ovaries are within the radiation field. And so when we give somebody pelvic radiation, we make them menopausal 100% of the time. And if you've got a young woman who is in her 20s or 30s and we've made her menopausal, her risk of osteoporosis is going to increase substantially because of her early menopause. As we've noted before, cervical cancer patients have multiple risk factors, including smoking and poor nutrition. So for these patients, I strongly consider a DEXA scan if they've had pelvic radiation, usually about 2 years after completion of radiation, and then every 2 years thereafter. If you start to see osteopenic changes, making recommendations about physical activity, exercise, some dietary changes is okay, but also don't hesitate to ask for help from endocrinology for optimization, especially in the setting of osteoporosis. We get asked a lot about calcium. The recommended intake for calcium is 1,200 milligrams of elemental calcium, which is best achieved with diet. So I basically tell my patients 4 servings of calcium a day, be it ice cream, cheese, yogurt, whatever they want. Supplement sparingly if they're unable to achieve this with diet, and that's because we know that taking supplemental calcium in tablet form increases the risk for kidney stones and for calcium deposits in the coronary arteries. And so you may potentiate cardiovascular disease with excess calcium intake, especially people who've already got underlying cardiovascular disease. So the adage of some is good, more is better is not true. Really try to optimize diet to help your patients, and then checking a vitamin D level is reasonable as well. Now, hormone replacement therapy is something that we discuss very often. Again, we know that premature menopause can occur due to radiation, even if we transpose ovaries, which is when we surgically kind of move them out of the radiative field in an attempt to protect them. And it's really important to take into account the patient's age and if her uterus is in place. If a patient is young and she's had radiation, she is menopausal. And so oftentimes using birth control pills are useful, one, because it provides substantial amount of estrogen and progestin, but also because of a patient's age, OCPs feel much more kind of natural versus putting them right on postmenopausal hormone replacement therapy. Now, if somebody is menopausal, combination hormone replacement therapy in the setting of a uterus that's still intact is recommended. So a radiated uterus can still get hyperplasia or cancer if somebody is given unopposed estrogen. So you want to make sure if there's a uterus in place that you give the estrogen plus the progestin. If the uterus has been removed, estrogen alone is sufficient. If there's a contraindication to hormone replacement therapy, that's things like migraine with aura, poorly controlled hypertension, history of renal or cardiovascular disease, history of DVT or PE, you can use an SSRI. We will typically start with venlafaxine and then dose escalate. If a patient doesn't want to do that, then some supplements that can be useful are black cohosh, vitamin E, and evening primrose oil. And actually, exercise and physical activity have shown to improve the symptoms of menopause and specifically hot flashes. So asking patients to engage in an exercise program is a good idea. Again, smoking cessation, very small thing to do, but there's a large impact. As oncologists, we don't do that well, referring patients to smoking cessation, but it's a really important thing for long-term kind of follow-up and general wellness. Only about 1 in 5 patients will quit smoking after a cancer diagnosis, and we do know that based on prior data, there is an increased risk for referral to GI pain management and physical therapy. I can't emphasize enough how significant the radiation side effects are in the setting of smoking. We know that there is a much greater risk for small bowel complications, so that's fistula and small bowel obstruction. You can have bladder and bowel complications, so you can have rectal stricture, rectovaginal fistula, fistulas from the bladder to the vagina, and then strictures of the ureter, which is the tube that connects the kidney to the bladder. So again, if somebody's not quit smoking, encourage them to do so. Endometrial cancer is followed a little bit less intensely, especially in the low-risk disease, which is more likely the ones that you're going to be able to see. Patients after year 5 just require a yearly pelvic examination. Much like cervical cancer, they do not need any routine imaging outside of a clinical concern for recurrence. There were studies that were done about a pap test at the top of the vagina to determine endometrial cancer recurrence, and it was demonstrated that a pap test identifies less than 1% of endometrial cancer recurrence. So outside of any other indication for pap tests, which would be things like prior history of cervical dysplasia, you don't need to do a pap for endometrial cancer surveillance, just a pelvic exam. Because obesity is so intertwined with endometrial cancer, it's really important to use this as kind of a teachable moment. And we know that this is important not just for reduction in cancer recurrence risk, but also for reduction in the metabolic syndrome and cardiovascular disease. So the U.S. Public Health Service Task Force recommends offering referral to a multi-component behavioral intervention if the BMI is greater than 30, which is the technical classification of obesity. The American Heart Association had recommendations for 150 minutes per week of moderate exercise. However, these were recently updated to indicate 300 minutes per week of moderate exercise or 150 minutes of vigorous activity, or a combination of the two. It's important to emphasize to patients that this does not need to happen in one sitting. Getting up and walking for 10 or 15 minutes and then coming back is completely acceptable as long as you get your minutes in. It's very important to optimize nutrition, make sure that things like diabetes are controlled for, and talk to your patient, be her advocate. Set very reasonable fitness goals and follow up with her. Make sure that you're encouraging her. And in cases where there is severe morbid obesity, referral to bariatric surgery is a very reasonable thing to do and may improve overall outcome. Now, genetic screening is very, very important. Again, we know that 1 in 4 women with ovarian cancer have a hereditary mutation that caused the cancer. The vast majority are in the hereditary breast and ovarian cancer syndrome block. The most common of these are BRCA1 and 2, but there are a whole host of other non-BRCA mutations. Very often we use panel tests now, so that tests for more than 30 specific gene mutations. And it's very important that some of these lesser penetrant mutations are evaluated for because they may also markedly increase risk, not just for your patients and secondary malignancies, but also for their family members. So again, for ovary, fallopian tube, and primary peritoneal cancers, all patients require genetic testing. If that has not been done already, send them to genetic counseling. Now I'd like to talk about resources and referrals for our gynecologic cancer survivors. And it's important to appreciate that GYN cancer survivors are unique. Very often they receive multimodality therapy, surgery with or without removal of their uterus or ovaries, radiation, and chemotherapy. And we understand that women have a number of competing priorities. They often are caring for their family, they are managing a career, they have concerns about fertility, all while undergoing their cancer treatment. And we see very often that they're the primary caregiver to somebody else, and that may be physically or financially. And so it's very important to engage support services that reflect the needs of these women because we want to optimize their quality of life during the survivorship period. They've gone through their cancer treatment, and what our goal is to make sure that physically they remain healthy, but also to make sure that their additional psychosocial needs are addressed. So it's important to do a needs assessment. And this doesn't even need to be something formal, but these are things that you can assess in the setting of conversation with your patient. So things that I want to talk about just briefly are physical symptoms resulting from treatment, financial toxicity, psychosocial functioning, sexual dysfunction, and fertility concerns, specifically in our premenopausal survivors. So physical symptoms can manifest in any number of ways, and really a multidisciplinary approach is the best way to address post-treatment physical symptoms. So we often will refer to physical medicine and rehabilitation. There are a number of reasons to refer to PM&R. And remember, PM&R is a medical subspecialty that will actually oversee physical and occupational therapy. Patients who've got chronic abdominal, pelvic, or lower extremity pain from radiation, fibrosis, or scarring, or patients who've got postoperative changes are good candidates for PM&R. Folks with chronic neuropathy, significant physical conditioning after cancer treatment, and lymphedema, which is chronic swelling of the extremities. And in the case of a GYN cancer, that's going to be the lower extremities. I think pretty much everybody would benefit from physical and occupational therapy. We know that these are resources that are great when there's a physical limitation, injury, or a chronic musculoskeletal issue that's impacting activities of daily living. Oftentimes, working with physical and occupational therapy includes upper and lower extremity strengthening. There can be pelvic floor physical therapy. So this is a specific type of physical therapy that helps relax the floors of the muscles of the pelvic floor, which can become scarred in the setting of pelvic radiation. But they can also have chronic pain as a result of stress and other kind of musculoskeletal issues. Lymphedema massage is manifested through these therapists as well. And then if patients have reduced physical activity because of post-treatment fatigue, they can really assist greatly in the setting of fatigue. Exercise physiology or exercise oncology is also a really great adjunct. Now, this service is good when there's not a physical limitation or injury, and there just may be the need for mild or moderate reconditioning. Or if this is a patient where exercise instruction is needed to kind of assist in disease recovery. So, really kind of talking to your patient and assessing what her needs are will help you triage between these three services. Now, palliative care is always a great service to involve with multiple indications. All patients who have had a cancer recurrence should be referred to palliative care. In fact, early palliative care referral is associated with improved survival. If the symptom or the sign the patient is experiencing is deemed to be directly related to the cancer or the cancer treatment, palliative care is appropriate. So this would be things like visceral or whole body pain. And whole body pain just kind of talks about pain that may be kind of existential in nature. Also, a kind of chronic management of neuropathy can be very skillfully taken care of by palliative care. When we talk about financial toxicity of treatments, it's really important to kind of understand that this is a manifestation of stress, and that physical symptoms can be a manifestation of financial toxicity as well. So beyond just the cost of cancer care, there's a whole host of other expenses that patients incur. Childcare, transportation, parking. They may have made changes in their diet or their eating habits, and all of these things are going to impact financial stability. It's very important to appreciate the added expenditures in the context of potential loss of income or reduction in benefits. And there are very robust data to demonstrate that many cancer patients undergo some degree of financial instability, in some cases all the way to bankruptcy. And that kind of stress at home can manifest in a number of different ways. So in this setting, several referrals can be useful. A finance manager, specifically if there are questions about billing or item costs. Social work or a case manager can be really helpful here because one, they can evaluate the home situation. So is there an imminent risk of the patient becoming homeless or losing housing? Is there substantial food insecurity affecting not just the patient, but the patient's family? They can also provide some supportive counseling, and then the social workers are a great adjunct because they know very often some philanthropic sources of funding for which the patient may qualify. Psychology is also a very important group here because if there's a mental health impact of the financial insecurity, they can really kind of help work through that stress in a therapeutic kind of forum. Psychosocial functioning is markedly affected by cancer treatment. So the stress of the cancer diagnosis, the treatment itself, and the impact on self and family is profound. It's very common for us to see adjustment disorders, which is when a patient may manifest anxiety or depression simply as a reaction to their disease and the stress around their disease. But many patients may also have more significant degrees of depression and anxiety, and we see this very commonly when it comes to a fear of cancer recurrence. General screening for mental health should occur at every visit. And for all of your patients, if a patient has suicidal ideations, involvement of psychiatry, social work, and law enforcement needs to be involved immediately. If patients need to be Baker acted because of an imminent threat to self, then that should be taken care of right away. If the need is not emergent, however, other resources do exist. So psychiatry is good for severe mental health issues, depression and anxiety, or if there's another axis 1 or 2 diagnosis that requires close follow-up, and for patients in whom medication is indicated. Psychology is a very useful addition in addition to psychiatry. Psychology is good if patients really don't want a medication for treatment, but I think that they're probably better utilized when therapy using any number of techniques such as cognitive behavioral therapy would be indicated. So these are sessions that occur kind of longitudinally and allow the patient to kind of work through the specific emotions and concerns that she has. Now, one thing that's independent of psychiatry and psychology is support groups. These are often done through the Department of Social Work, and these are great because they allow patients to discuss shared experiences. They realize that they're not alone with side effects, long-term consequences. I've participated in many of these and have really kind of seen the evolution of patients who went from having substantial distress to really feeling a sense of community. Support groups exist by disease site as well as for particular situations. So for example, if your patient has a colostomy, we have a very specific colostomy support group. Social work consult would be indicated here, and they can often triage to the most appropriate support group. For GYN cancer treatments, recognizing that, again, we use surgery, chemotherapy, and radiation, we see a number of changes that can lead to sexual dysfunction. We induce menopause, especially in young women. That can lead to a lack of desire, vaginal dryness, and muscle spasm, which can be associated with pain during sexual intercourse. Radiation to the pelvis can cause fibrosis or scarring of the pelvic floor muscles. Radiation can also cause vaginal agglutination, so it sticks together. And if this is not addressed, stenosis or narrowing, and in the most severe cases, complete obliteration of the vagina, and it closes up. Physical changes to the body occur very commonly. Often our surgeries are done in an open fashion. So patients may have a large scar if they have an ostomy, or if they've had substantial kind of changes in their body makeup or weight loss. It's very common for us to see some degree of body dysmorphia. So in the setting of sexual dysfunction, engaging a sexual therapist is a really good idea. These are usually effective when the patient has specific needs more related to desire and partner intimacy. You know, we often tell our patients that the brain is the most sexual organ. So really going through things as they relate to desire for sex or disinterest in sex is often done or managed most effectively using a sexual therapist. Physical therapy can be good when pelvic floor PT is needed. Pelvic floor physical therapy really kind of stretches the muscles. It prevents rigidity, and if started early, it can actually reduce pelvic fibrosis. There's a number of techniques that are used, some of those including vaginal dilators to prevent stenosis, some include nerve stimulators. These are things that should occur kind of chronically and with ongoing repeated sessions, but this can be almost, if not more effective than trying to use medical management for chronic pelvic pain. At Sylvester, we have a specific clinic called the Music Clinic, and this deals with vaginal dryness and atrophy or thinning in women as a result of their anti-estrogen therapy or other cancer treatments. And this isn't just for GYN cancer survivors, this is for all female cancer survivors. The Music Clinic does utilize dilators, but they also will kind of address topical and other medical treatments for the support of vaginal health. And again, kind of the longitudinal impact of this is really kind of increased comfort with kind of ongoing management of vaginal long-term side effects. And again, psychology is great to involve if a patient has substantial body dysmorphia leading to depression and anxiety. And then finally, fertility concerns. You know, we know that there's a lot of young women who are being diagnosed with cancer, and we're offering fertility-sparing treatments because we want women to be able to have the opportunity to try and achieve pregnancy, even in the setting of a cancer diagnosis. And so it's very important to get these folks involved early. So an infertility specialist, specifically in the subspecialty of reproductive endocrinology and infertility, what these folks do is they oversee assisted reproductive technology. That's things like in vitro fertilization, egg retrieval, and intrauterine insemination. It's very good, even before cancer treatments get started, to refer these patients if it's unclear if she can get pregnant, if in the survivorship setting she's been trying to get pregnant but she's not succeeding. If you have a patient who's got a known germline genetic mutation and thus a hereditary cancer risk, and she wants to talk about ways to reduce the risk in a baby. And then if you've got a patient who is young, doesn't think today is the right day to get pregnant, but wants to bank eggs or embryos for later use. These are all great things to talk about with somebody from infertility. We know that being overweight and obese markedly reduces fecundity, which is the ability to get pregnant. And so optimizing weight through healthy eating and exercise can be very helpful in achieving pregnancy. In fact, we've seen marked increases in rates of pregnancy when patients have just a 15% weight loss. So getting nutritionists involved here early, especially in your overweight or obese patients, is great. It's also important to recognize that in the setting of desired pregnancy, optimizing other medical conditions like diabetes and high blood pressure will allow for increased rates of completion of pregnancy and reduction in pregnancy-associated complications. It's very helpful to send somebody to an obstetrician to discuss preconception counseling and kind of what things would look like in the setting of a pregnancy. And then there's a number of advocacy groups actually that will assist in paying for the cost of some of these assisted reproductive technologies. think the one that's probably the most famous is the Lance Armstrong Foundation. Um, there is an application that is required to apply for funds from Lance Armstrong. And they really kind of take into account age, types of cancer treatments, and things like that. But I've had some patients funded through this mechanism. So in summary, each patient will come with a unique set of concerns in the survivorship period. It's really important to listen very carefully to what they're telling you and to conduct a very thorough physical exam. And one of the things that I think is probably the most important about all of these support services is that you need to refer often and refer early. Delays in consultation can lead to worse long-term side effects and reduced quality of life. And when we have all of these services, they all work in conjunction with each other, and really getting multiple people involved to address all of these niche issues within the survivorship period is crucial to optimizing care. So thank you very much for your attention.